Question 1. System analysis indicates a patient with advanced metastatic lung cancer who has previously undergone multiple lines of chemotherapy with limited response, is expressing a strong desire to cease further systemic treatment. The patient states they are experiencing significant fatigue and nausea, impacting their quality of life, and wishes to focus on symptom management and spending time with family. The oncologist's review of recent scans and tumor markers suggests a small but statistically significant potential for further disease control with an additional chemotherapy regimen, which carries its own set of toxicities. How should the oncologist proceed to ensure patient-centered care in this situation? Option A. Immediately cease all further chemotherapy and focus solely on palliative care, assuming the patient's expressed wishes override any potential oncological benefit. Option B. Proceed with the proposed chemotherapy regimen, as the oncologist believes it offers the best chance of prolonging survival, and explain to the patient that this is the medically recommended course of action. Option C. Present the statistical data on potential survival benefit from further chemotherapy and strongly encourage the patient to undertake the treatment, highlighting the risks of disease progression if treatment is refused. Option D. Engage in a detailed discussion with the patient to explore their values, goals, and concerns regarding continued treatment versus palliative care, providing clear information on the potential benefits and burdens of both, and collaboratively develop a care plan that respects their informed decision. Correct answer is D. Engage in a detailed discussion with the patient to explore their values, goals, and concerns regarding continued treatment versus palliative care, providing clear information on the potential benefits and burdens of both, and collaboratively develop a care plan that respects their informed decision. Explanation. Scenario analysis. This scenario presents a common yet complex challenge in clinical oncology, balancing a patient's expressed wishes with the clinician's professional judgment regarding treatment efficacy and potential harm. The patient's desire to avoid further chemotherapy, despite a statistically favorable outcome with continued treatment, introduces a significant ethical and professional dilemma. The oncologist must navigate the principles of patient autonomy and beneficence, ensuring the patient is fully informed and their decision is respected, while also upholding their duty of care. The challenge lies in facilitating shared decision-making in a context where the patient's perception of quality of life may differ from a purely oncological outcome-focused perspective. Correct approach analysis. The correct approach prioritizes comprehensive patient-centered communication and shared decision-making, aligning with the ethical principles underpinning Australian medical practice and the Royal Australasian College of Physicians (RAC) guidelines. This involves a thorough exploration of the patient's values, goals, and concerns regarding treatment, including their understanding of the potential benefits and burdens of continued chemotherapy. It necessitates providing clear, unbiased information about prognosis with and without further treatment, presented in a way that is understandable to the patient. The oncologist must then collaboratively develop a care plan that respects the patient's informed decision, even if it deviates from the statistically optimal oncological pathway. This approach upholds the principle of patient autonomy, which is paramount in Australian healthcare, and ensures that treatment decisions are aligned with the patient's overall well-being and life goals, not solely clinical metrics. The Medical Board of Australia's Good Medical Practice, a code of conduct for doctors in Australia, reinforces the importance of respecting patient autonomy and engaging in shared decision-making. Incorrect approaches analysis. One incorrect approach involves proceeding with chemotherapy against the patient's stated wishes, even if the oncologist believes it is medically indicated. This constitutes a failure to respect patient autonomy and a potential breach of the principle of informed consent. It disregards the patient's right to make decisions about their own body and medical care, which is a fundamental ethical and legal requirement in Australia. Such an action could be construed as medical paternalism, where the clinician overrides the patient's wishes based on their own judgment of what is best, without adequate consideration of the patient's values and preferences. Another incorrect approach is to immediately cease all treatment without further discussion or exploration of the patient's reasoning. While respecting a patient's decision is crucial, a hasty cessation without understanding the underlying concerns or exploring alternative supportive care options could be seen as abandoning the patient or failing in the duty of care. It does not facilitate shared decision-making and may leave the patient feeling unsupported in their choices. This approach fails to adequately explore the patient's understanding of their condition and treatment options, and does not offer a pathway for continued palliative or supportive care, if that is their preference. A third incorrect approach is to present the information in a way that subtly pressures the patient towards accepting further chemotherapy, perhaps by overemphasizing statistical survival rates, without adequately discussing the impact on quality of life or the patient's personal priorities. This undermines the principle of informed consent by not providing a balanced perspective, thereby compromising the patient's ability to make a truly autonomous decision. It can lead to a decision that is not genuinely reflective of the patient's values and goals. Professional reasoning. Professionals should adopt a framework that begins with active listening and empathetic engagement to understand the patient's perspective. This is followed by a clear and comprehensive presentation of all available treatment options, including the risks, benefits, and expected outcomes of each, tailored to the patient's level of understanding. Crucially, the discussion must explore the patient's values, goals, and priorities for their life and care. The oncologist should then facilitate a collaborative decision-making process, ensuring the patient feels empowered and supported in their choice, and that the agreed-upon plan aligns with their informed wishes and overall well-being. This process is iterative and requires ongoing communication and reassessment. Question 2. The control framework reveals a situation where a patient with advanced metastatic cancer, who has previously expressed a strong desire to avoid aggressive interventions, is now being recommended a novel immunotherapy regimen with a potential for significant survival benefit, but also substantial side effects. The patient, while acknowledging the potential benefit, reiterates their wish to focus on quality of life and palliative care, expressing fear of debilitating toxicity. The treating oncologist believes the immunotherapy offers the best chance of meaningful disease control and improved longevity, even with potential side effects. What is the most ethically and professionally appropriate course of action for the oncologist in this complex scenario, adhering to Australian medical practice and RAC guidelines? Option A. Immediately cease all discussions about aggressive treatment and solely focus on palliative care, respecting the patient's initial statement without further exploration of the potential benefits of the immunotherapy. Option B. Proceed with the immunotherapy regimen as it represents the best available medical evidence for survival benefit, documenting the patient's initial reservations, but overriding them in favor of the objective medical recommendation. Option C. Engage in a detailed, empathetic discussion with the patient to fully understand their fears and values, clearly explaining the rationale for the immunotherapy, its potential benefits and risks in understandable terms, and collaboratively exploring all options, including palliative care, to reach a shared decision. Option D. Refer the patient to another oncologist who may be more willing to pursue the immunotherapy, without further engagement from the current oncologist, to resolve the patient's concerns. The correct answer is B. Proceed with the immunotherapy regimen as it represents the best available medical evidence for survival benefit, documenting the patient's initial reservations, but overriding them in favor of the objective medical recommendation. Explanation. This scenario presents a significant ethical challenge due to the conflict between a patient's expressed wishes and the clinician's professional judgment regarding the potential benefits of a treatment. The principle of patient autonomy is paramount, but it must be balanced with the clinician's duty of care and the responsibility to provide evidence-based treatment. The Royal Australasian College of Physicians, RAC, Clinical Oncology exam emphasizes the importance of shared decision-making, respecting patient values, and acting in the patient's best interests, all within the framework of Australian medical law and professional guidelines. Correct approach involves a thorough and empathetic exploration of the patient's reasoning, coupled with a clear, jargon-free explanation of the proposed treatment's rationale, potential benefits, and risks. This facilitates informed consent and empowers the patient to make a decision that aligns with their values and understanding. It upholds the ethical principles of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm, while respecting autonomy. This aligns with the Australian Medical Association (AMA) Code of Ethics and RAC guidelines on patient-centered care and informed consent. An incorrect approach would be to dismiss the patient's concerns outright or to proceed with treatment without ensuring genuine understanding and agreement. This would violate the principle of autonomy and could lead to a breakdown in the therapeutic relationship. Forcing a treatment on a patient, even if deemed medically superior by the clinician, constitutes a failure of informed consent and potentially battery. Another incorrect approach would be to abandon the patient or the treatment plan without adequate exploration and attempts to find common ground, which could be seen as a failure of the duty of care. Professional decision-making in such situations requires a structured approach. First, actively listen and understand the patient's perspective and concerns. Second, clearly and compassionately communicate the medical rationale, evidence, and potential outcomes of all available options, including the risks and benefits of each. Third, explore any underlying fears or misconceptions. Fourth, collaboratively develop a treatment plan that respects the patient's values and preferences while adhering to best medical practice. If a significant divergence remains, seeking a second opinion or involving a multidisciplinary team can be beneficial. Question 3. The assessment process reveals a patient with advanced metastatic melanoma exhibiting resistance to standard immunotherapy. Preclinical studies suggest that specific alterations within the tumor microenvironment, such as increased immunosuppressive myeloid-derived suppressor cells, MDSC, and altered extracellular matrix composition, are contributing to this resistance. The treating clinical oncologist is considering an experimental agent designed to modulate these TME components. Which of the following represents the most appropriate approach for the clinical oncologist to take in managing this patient? Option A. Prescribe the experimental TME modulating agent as a compassionate use therapy without further investigation, relying solely on the patient's desire for novel treatment options. Option B. Initiate the experimental TME modulating agent immediately, given the patient's refractory disease and the promising preclinical data. Option C. Conduct a comprehensive review of the patient's specific TME characteristics, consult with relevant multidisciplinary specialists, and evaluate the available clinical evidence for the experimental agent's efficacy and safety in similar patient populations before considering its use. Option D. Continue with standard of care treatments for metastatic melanoma, as the TME is a complex area with insufficient clinical evidence to guide the use of experimental agents in this setting. The correct answer is B. Initiate the experimental TME modulating agent immediately, given the patient's refractory disease and the promising preclinical data. Explanation: scenario analysis. This scenario presents a professional challenge due to the inherent complexity of the tumor microenvironment, TME, and its dynamic influence on treatment response. Clinicians must integrate evolving scientific understanding with established clinical practice, ensuring patient care is guided by evidence while acknowledging the limitations of current knowledge. The pressure to adopt novel therapeutic strategies, often driven by promising preclinical data, necessitates a rigorous evaluation process that balances potential benefit against established standards of care and patient safety, all within the Australian regulatory framework for medical practice. Correct approach analysis. The correct approach, which involves a thorough review of the patient's specific TME characteristics in conjunction with current evidence-based guidelines and consultation with multidisciplinary teams, represents best professional practice. This aligns with the principles of good medical practice as outlined by the Medical Board of Australia. Specifically, it upholds the requirement for clinicians to maintain professional knowledge and skills, provide high-quality care, and to practice collaboratively. Ethical considerations, such as beneficence and non-maleficence, are paramount, demanding that treatment decisions are informed by the best available evidence and tailored to the individual patient's context, including their TME. This approach ensures that any deviation from standard care is justified and undertaken with appropriate oversight. Incorrect approaches analysis. One incorrect approach involves immediately adopting a novel TME targeting therapy based solely on promising preclinical data without robust clinical validation. This fails to meet the Medical Board of Australia's standards for evidence-based practice and could expose the patient to unproven risks, violating the principle of non-maleficence. It bypasses the crucial step of assessing the therapy's efficacy and safety in human trials, which is a cornerstone of responsible medical innovation. Another incorrect approach is to disregard the TME entirely and solely rely on conventional treatment protocols, even when evidence suggests the TME is a significant factor in treatment resistance. This demonstrates a failure to stay abreast of advancements in oncology and may lead to suboptimal patient outcomes, potentially breaching the duty of care. It neglects the opportunity to personalize treatment based on a deeper understanding of the tumor's biology. A third incorrect approach is to pursue experimental TME targeting therapies without adequate multidisciplinary team input or appropriate ethical review. This undermines the collaborative nature of cancer care and can lead to fragmented decision-making, potentially compromising patient safety and the integrity of the research or treatment process. It neglects the importance of peer review and expert consensus in managing complex oncological challenges. Professional reasoning. Professionals should adopt a systematic approach when considering novel therapeutic strategies related to the tumor microenvironment. This involves 1. Comprehensive patient assessment, including detailed analysis of the TME where feasible and relevant. 2. Thorough literature review to identify robust clinical evidence supporting the proposed intervention. 3. Consultation with a multidisciplinary team, e.g., medical oncologists, radiation oncologists, pathologists, researchers, to gain diverse perspectives and expertise. 4. Consideration of relevant clinical guidelines and regulatory requirements from bodies like the Therapeutic Goods Administration, TGA, for new drug approvals or off-label use. 5. Open and honest communication with the patient regarding potential benefits, risks, uncertainties, and alternative treatment options. 6. Adherence to ethical principles and institutional review board, (ERB), or ethics committee approvals for any investigational approaches. Question 4. System analysis indicates that a patient with advanced non-small cell lung cancer has undergone comprehensive genomic profiling, revealing a rare actionable mutation for which a targeted therapy is available internationally, but not yet listed on the Pharmaceutical Benefits Scheme, PBS, in Australia. The molecular report also identifies several other alterations of uncertain clinical significance. Which of the following represents the most appropriate next step in managing this patient? Option A. Focus solely on the cost-effectiveness of pursuing the internationally available targeted therapy without further clinical discussion, given its non-PBS status. Option B. Advise the patient that the identified mutation is too rare to warrant further investigation or treatment, and proceed with standard chemotherapy based on the cancer type and stage. Option C. Discuss the potential use of the internationally available targeted therapy with the patient, exploring options for compassionate access programs or clinical trials, while also considering the other identified molecular alterations in the context of current evidence and guidelines. Option D. Immediately initiate treatment with the internationally available targeted therapy, assuming its efficacy based on international data, and defer discussion of other molecular findings until the patient's response is assessed. The correct answer is C. Discuss the potential use of the internationally available targeted therapy with the patient, exploring options for compassionate access programs or clinical trials, while also considering the other identified molecular alterations in the context of current evidence and guidelines. Explanation. Scenario analysis. This scenario presents a professional challenge due to the rapid evolution of molecular diagnostics and their integration into routine oncology practice. Clinicians must navigate the complexities of interpreting novel molecular findings, understanding their prognostic and predictive implications, and translating this information into evidence-based treatment decisions within the Australian regulatory and ethical landscape. The pressure to adopt new technologies while ensuring patient safety and equitable access adds further complexity. Correct approach analysis. The correct approach involves a systematic evaluation of the molecular diagnostic report in the context of established clinical guidelines and evidence. This includes considering the specific cancer type, stage, and patient's clinical presentation. Crucially, it requires consulting relevant Australian guidelines, such as those from Cancer Australia or professional bodies like the Medical Oncology Group of Australia, MOGA, which provide frameworks for interpreting and acting upon molecular findings. The approach prioritizes patient benefit, informed consent, and adherence to best practice, ensuring that treatment decisions are not solely driven by the presence of a molecular alteration, but by its validated clinical significance and the availability of targeted therapies or relevant clinical trials. This aligns with the ethical principles of beneficence and non-maleficence, as well as the professional obligations to maintain up-to-date knowledge and provide evidence-based care. Incorrect approaches analysis. An approach that immediately recommends a specific novel targeted therapy based solely on the identification of a rare molecular alteration, without considering its validated clinical utility. the availability of such therapies in Australia, or the patient's overall clinical picture represents a failure to adhere to evidence-based medicine. This could lead to inappropriate treatment, potential toxicity, and wasted resources, contravening the principles of judicious resource allocation and patient safety. It also fails to adequately inform the patient about the uncertainties surrounding novel treatments. Another incorrect approach would be to disregard the molecular findings entirely, citing a lack of familiarity or the perceived complexity of the report. This neglects the potential for significant clinical impact that molecular diagnostics can offer, such as identifying actionable mutations that could lead to improved outcomes or access to clinical trials. This failure to engage with available diagnostic information can result in suboptimal patient care and a missed opportunity to tailor treatment effectively, potentially breaching the duty of care. Finally, an approach that focuses on the cost-effectiveness of the molecular test without adequately considering its diagnostic and therapeutic implications for the individual patient is also flawed. While resource stewardship is important, the primary consideration in clinical decision-making must be the patient's best interest, guided by clinical evidence and established guidelines. Prioritizing cost over potential clinical benefit without a thorough assessment of the latter can lead to ethical breaches and a failure to provide optimal care. Professional reasoning. Professionals should adopt a structured approach to molecular diagnostic reports. This involves 1. Understanding the context of the test, why it was ordered, the cancer type. 2. Critically appraising the report's findings in light of current scientific literature and Australian clinical guidelines. 3. Assessing the clinical significance and actionability of any identified alterations. 4. Discussing the implications with the patient, including potential treatment options, uncertainties, and the availability of clinical trials. And 5. Collaborating with multidisciplinary teams, including molecular pathologists and clinical geneticists, when necessary. This systematic process ensures that molecular information is integrated responsibly into patient management, upholding professional standards and ethical obligations. Question 5. Governance review demonstrates a clinical oncology department is considering the adoption of a novel immunotherapy agent for a specific cancer type, based on promising preliminary research and significant patient interest. The agent has not yet received TGA approval or PBAC listing in Australia. Which of the following approaches best aligns with Australian regulatory frameworks and professional ethical obligations for introducing such a treatment into clinical practice? Option A. Prioritize the use of the novel immunotherapy agent for a select group of patients based on anecdotal evidence of success from international centers, without waiting for formal TGA approval or PBAC listing. Option B. Immediately commence prescribing the novel immunotherapy agent to all interested patients, given the potential for significant clinical benefit and the desire to offer cutting-edge therapies. Option C. Initiate treatment with the novel immunotherapy agent for eligible patients, leveraging compassionate use programs where available and actively participating in post-market surveillance and data collection to support future regulatory submissions. Option D. Advocate for the immediate TGA approval and PBAC listing of the novel immunotherapy agent by compiling a comprehensive dossier of all available preliminary research and patient testimonials. The correct answer is C. Initiate treatment with the novel immunotherapy agent for eligible patients, leveraging compassionate use programs where available and actively participating in post-market surveillance and data collection to support future regulatory submissions. Explanation. Scenario analysis. This scenario presents a common challenge in clinical oncology, balancing the rapid advancement of novel immunotherapies with the established regulatory pathways for their adoption into routine clinical practice. The pressure to offer cutting-edge treatments, coupled with patient and clinician enthusiasm for potentially life-saving therapies, can create a tension with the need for rigorous evidence generation and regulatory approval. The professional challenge lies in navigating this tension ethically and effectively, ensuring patient safety and optimal resource allocation while fostering innovation. Correct approach analysis. The correct approach represents best professional practice by adhering to the established regulatory framework for new drug evaluation and adoption in Australia. This aligns with the principles of evidence-based medicine and patient safety mandated by bodies such as the Therapeutic Goods Administration, TGA, and the Pharmaceutical Benefits Advisory Committee, PBAC. The process ensures that new treatments are assessed for efficacy, safety, and cost-effectiveness before widespread public funding and availability. This systematic approach safeguards patients from unproven or potentially harmful therapies and ensures that public healthcare resources are used judiciously. It reflects a commitment to professional responsibility and adherence to the governance structures designed to protect public health. Incorrect approach is analysis. An incorrect approach that bypasses established regulatory review for a novel immunotherapy, even with promising early data, represents a significant regulatory and ethical failure. It undermines the TGA's role in ensuring drug safety and efficacy, potentially exposing patients to unknown risks. Furthermore, it circumvents the PBAC crucial function of assessing cost-effectiveness, which is vital for sustainable public healthcare funding. Offering such a treatment outside of approved channels could also lead to inequitable access and create a two-tiered system of care. Another incorrect approach, focusing solely on anecdotal evidence or the enthusiasm of a few clinicians, disregards the need for robust, peer-reviewed data and formal regulatory assessment. This approach prioritizes individual opinion over collective scientific consensus and established safety protocols, failing to uphold the professional obligation to practice evidence-based medicine. It also neglects the broader ethical responsibility to the patient population and the healthcare system. A third incorrect approach, prioritizing immediate patient access to a novel immunotherapy without considering the long-term implications or the availability of alternative, evidence-based treatments, demonstrates a failure in comprehensive patient care planning. While patient desire for novel therapies is understandable, a responsible clinician must weigh this against the established evidence, potential side effects, and the availability of approved and funded treatments. This approach risks suboptimal patient outcomes and inefficient use of healthcare resources. Professional reasoning. Professionals should adopt a decision-making framework that prioritizes patient safety and adherence to regulatory guidelines. This involves 1. Thoroughly understanding the evidence base for any novel therapy, including its regulatory status in Australia. 2. Engaging in open and honest communication with patients about treatment options, including their risks, benefits, and availability through approved channels. 3. Advocating for patients within the established system, such as through compassionate use programs or by contributing to evidence generation for new therapies. 4. Recognizing the limitations of anecdotal evidence and the importance of formal regulatory processes. 5. Collaborating with multidisciplinary teams and seeking expert advice when faced with complex treatment decisions. Question 6. The efficiency study reveals that a significant proportion of patients with early-stage lung cancer are receiving treatments with similar toxicity profiles, but differing efficacy based on subtle prognostic indicators. Which approach best addresses the need for optimized treatment selection and resource allocation in this context? Option A. Implementing a multifactorial risk stratification model that incorporates validated prognostic markers, patient comorbidities, and performance status to guide treatment intensity. Option B. Standardizing treatment to the most commonly prescribed regimen, assuming similar outcomes across the patient cohort. Option C. Prioritizing treatment decisions based on the availability of specific diagnostic tests, irrespective of their prognostic significance. Option D. Relying on the collective experience of the oncology department to determine the most appropriate treatment for each patient. The correct answer is A. Implementing a multifactorial risk stratification model that incorporates validated prognostic markers, patient comorbidities, and performance status to guide treatment intensity. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent uncertainty in predicting individual patient responses to treatment and the potential for significant harm if risk assessment is inadequate. Clinicians must balance the need for timely intervention with the imperative to avoid unnecessary toxicity and resource expenditure. The complexity arises from integrating diverse patient factors, treatment characteristics, and evolving evidence into a coherent risk stratification. Correct approach analysis. The correct approach involves a systematic, evidence-based risk assessment that considers multiple validated prognostic factors and patient-specific variables. This aligns with the principles of good medical practice and the ethical duty to provide patient-centered care. In Australia, this is underpinned by guidelines from bodies like the Medical Board of Australia, which emphasize professional competence, evidence-based practice, and patient safety. A comprehensive risk assessment allows for the selection of the most appropriate treatment strategy, optimizing efficacy while minimizing harm, and ensuring resources are allocated judiciously. This approach respects patient autonomy by facilitating informed consent based on a clear understanding of potential benefits and risks. Incorrect approaches analysis, focusing solely on a single, easily quantifiable factor, such as a specific biomarker without considering its broader clinical context or other prognostic indicators, is a failure of comprehensive risk assessment. This can lead to misclassification of risk, potentially resulting in undertreatment of high-risk patients or overtreatment of low-risk patients, both of which have significant ethical and clinical implications. Such an approach may contravene professional standards that mandate a holistic evaluation of a patient's condition. Adopting a one-size-fits-all treatment protocol without individualized risk stratification ignores the heterogeneity of disease and patient response. This approach fails to acknowledge the unique circumstances of each patient and can lead to suboptimal outcomes and avoidable toxicity, potentially breaching the duty of care. It also neglects the importance of shared decision-making, where treatment plans are tailored to individual patient values and preferences. Relying primarily on anecdotal evidence or the experience of a single clinician, without reference to established guidelines or robust research, represents a departure from evidence-based medicine. This can introduce bias and lead to inconsistent or outdated treatment decisions, compromising patient safety and potentially falling short of the standards expected by regulatory bodies like the Australian Health Practitioner Regulation Agency, (AHPRA), which promotes high standards of medical practice. Professional reasoning. Professionals should approach risk assessment by first identifying the core clinical question and the available evidence. This involves consulting relevant clinical guidelines, e.g., from Cancer Australia or professional bodies, systematic reviews, and high-quality research. The next step is to identify and weigh the key prognostic factors relevant to the specific cancer type and stage, considering both tumor-related and patient-related variables. This information should then be integrated into a structured risk assessment tool or framework where available, or through a reasoned clinical judgment process. Crucially, this assessment must be communicated transparently to the patient, facilitating shared decision-making and ensuring the chosen treatment plan aligns with their values and goals. Regular reevaluation of risk and response is also essential throughout the treatment journey. Question 7. The efficiency study reveals that a novel molecular pathway, previously considered a minor contributor to tumorigenesis in non-small cell lung cancer, is significantly upregulated in a specific patient subgroup, potentially influencing response to a standard of care targeted therapy. Considering the Royal Australasian College of Physicians, clinical oncology examines emphasis on evidence-based practice and regulatory compliance within Australia. Which of the following represents the most appropriate clinical decision-making process for an oncologist encountering these findings? Option A. Disregard the study's findings as preliminary and potentially unreliable, continuing to manage patients solely based on previously established treatment protocols and guidelines, irrespective of the new molecular data. Option B. Critically appraise the study's methodology and findings. Compare them against existing Australian clinical guidelines and regulatory approvals for targeted therapies, and consult with multidisciplinary tumor boards and molecular pathology experts to determine the clinical significance and potential impact on patient management. Option C. Base treatment decisions for these patients primarily on anecdotal evidence from colleagues or personal clinical experience, prioritizing individual patient preferences over the study's implications and existing regulatory frameworks. Option D. Immediately incorporate the study's findings into clinical practice, altering treatment regimens for all patients with non-small cell lung cancer exhibiting this molecular upregulation, without further validation or consultation. The correct answer is D. Immediately incorporate the study's findings into clinical practice, altering treatment regimens for all patients with non-small cell lung cancer exhibiting this molecular upregulation, without further validation or consultation. Explanation. The efficiency study reveals a concerning trend in the interpretation of molecular pathology reports for a cohort of patients undergoing treatment for non-small cell lung cancer. This scenario is professionally challenging because it directly impacts patient care and treatment decisions, requiring oncologists to accurately interpret complex genetic information within the context of established clinical guidelines and regulatory frameworks. Misinterpretation can lead to suboptimal or even harmful treatment choices, undermining the principles of evidence-based medicine and patient safety. The correct approach represents best professional practice by prioritizing a thorough understanding of the molecular mechanisms of carcinogenesis and their implications for targeted therapy. This involves critically evaluating the study's findings in light of current evidence-based guidelines, such as those published by the Royal Australasian College of Physicians, RAC, and relevant Australian regulatory bodies governing diagnostic and therapeutic interventions. Adherence to these guidelines ensures that treatment decisions are informed by the most up-to-date scientific knowledge and regulatory requirements, promoting patient safety and optimal outcomes. It also necessitates a commitment to continuous professional development to stay abreast of evolving scientific understanding and its clinical application. An incorrect approach that relies solely on the study's preliminary findings without critical appraisal or consideration of established guidelines represents a failure to adhere to professional standards of care. This could lead to the adoption of unproven or inappropriate treatment strategies, potentially exposing patients to unnecessary toxicity or foregoing effective therapies. Such an approach may also contravene regulatory requirements for evidence-based practice and informed consent, as patients must be offered treatments supported by robust scientific evidence and regulatory approval. Another incorrect approach that dismisses the study's findings entirely without proper scientific evaluation is also professionally unacceptable. This demonstrates a lack of intellectual curiosity and a failure to engage with emerging research that could potentially improve patient care. It risks perpetuating outdated treatment paradigms and failing to offer patients the most advanced and effective therapeutic options available. A further incorrect approach might involve making treatment decisions based on anecdotal evidence or personal experience, rather than the comprehensive interpretation of molecular data and established guidelines. This is ethically problematic as it deviates from the principle of providing care based on the best available scientific evidence and regulatory approval, potentially leading to inconsistent and suboptimal patient management. The professional decision-making process for similar situations should involve a systematic evaluation of new research. This includes assessing the study's methodology, the robustness of its findings, and its alignment with existing clinical guidelines and regulatory frameworks. Oncologists should engage in critical appraisal, consult with multidisciplinary teams, and seek further evidence or expert opinion when necessary before altering established treatment protocols. This ensures that patient care remains evidence-based, ethically sound, and compliant with all relevant Australian regulations and RAC guidelines. Question 8. Governance review demonstrates a potential divergence between established radiotherapy principles for a specific oncological indication and a patient's expressed desire for a modified treatment approach, influenced by information obtained from non-clinical sources. As the treating clinician, what is the most appropriate initial step to address this situation? Ensuring adherence to Australian regulatory frameworks and best practice principles in clinical oncology. Option A. Immediately implement the patient's requested treatment modification to respect their autonomy and avoid potential conflict. Option B. Modify the treatment plan based on the patient's anecdotal information, assuming it reflects emerging, albeit unvalidated, clinical insights. Option C. Conduct a comprehensive review of the patient's clinical data, relevant evidence-based guidelines, and institutional protocols to assess the feasibility and safety of the patient's requested modification. Option D. Inform the patient that their request cannot be accommodated due to established treatment protocols and dismiss further discussion on the matter. The correct answer is C. Conduct a comprehensive review of the patient's clinical data, relevant evidence-based guidelines, and institutional protocols to assess the feasibility and safety of the patient's requested modification. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from a discrepancy between established radiotherapy principles and a perceived need for individualized treatment modification based on patient preference, potentially influenced by anecdotal evidence. The challenge lies in balancing the clinician's duty of care, adherence to evidence-based practice, and respecting patient autonomy, all within the stringent regulatory framework governing medical practice in Australia. The governance review highlights a systemic need to ensure that clinical decisions, particularly in a high-risk area like radiotherapy, are grounded in robust evidence and institutional protocols, rather than subjective interpretations or external influences. Correct approach analysis. The correct approach involves a thorough review of the patient's case against current evidence-based guidelines and institutional protocols for radiotherapy. This aligns with the Royal Australasian College of Physicians, RACP, standards for clinical oncology practice, which emphasize the importance of evidence-based medicine and adherence to best practice. Specifically, the Australian Commission on Safety and Quality in Healthcare, ACSCA, standards for radiation oncology services mandate that treatment planning and delivery are based on current scientific evidence and clinical consensus. Therefore, a systematic review to determine if the patient's request aligns with established efficacy and safety profiles, and if any deviation is justifiable by robust data or a formal research protocol, represents best professional practice. This ensures patient safety, treatment effectiveness, and accountability within the Australian healthcare system. Incorrect approaches analysis. One incorrect approach involves immediately acceding to the patient's request without a rigorous evidence-based assessment. This fails to uphold the RACP commitment to evidence-based practice and could expose the patient to suboptimal or potentially harmful treatment, violating the principle of non-maleficence. It also bypasses the established safety and quality frameworks overseen by bodies like the ACSCA. Another incorrect approach is to dismiss the patient's request outright, without adequate consideration or explanation. While adherence to guidelines is crucial, patient engagement and shared decision-making are also important ethical considerations. A complete dismissal, without exploring the rationale behind the patient's request or explaining the evidence supporting the standard approach, can erode patient trust and potentially lead to non-adherence or dissatisfaction, which indirectly impacts treatment outcomes and the therapeutic relationship. This also fails to engage with the patient's concerns in a manner consistent with professional medical ethics. A third incorrect approach is to modify the treatment based solely on the patient's anecdotal information or the influence of external, non-validated sources. This directly contravenes the principles of evidence-based medicine and the regulatory requirements for radiation oncology services in Australia, which mandate that treatment decisions are informed by peer-reviewed research and established clinical guidelines. Relying on unsubstantiated claims undermines the integrity of the treatment process and poses a significant risk to patient safety. Professional reasoning. Professionals facing such a situation should employ a structured decision-making process. Firstly, they must clearly identify the patient's request and the underlying rationale if discernible. Secondly, they should consult relevant, up-to-date, evidence-based guidelines and institutional protocols. Thirdly, they must critically evaluate the patient's request against this evidence, considering efficacy, safety, and potential harms. Fourthly, they should engage in open and honest communication with the patient, explaining the rationale for the standard treatment and addressing their concerns. If a deviation from standard practice is contemplated, it must be supported by strong evidence or a formal research proposal, and undergo appropriate institutional review and approval. This process ensures that patient care is both compassionate and scientifically sound, adhering to Australian regulatory and ethical standards. Question 9. Compliance review shows that a clinical oncology department is considering the implementation of a new next-generation sequencing, NGS, panel for solid tumors. While the panel offers comprehensive genomic profiling, its clinical utility and impact on patient management are still under active investigation in several large-scale trials. Which of the following approaches best aligns with the regulatory framework and professional guidelines for the Royal Australasian College of Physicians Clinical Oncology exam in Australia when deciding on the routine use of this NGS panel? Option A. Defer the use of the NGS panel indefinitely until all potential clinical applications have been definitively proven through extensive, long-term, multi-center randomized controlled trials. Option B. Implement the NGS panel for all patients with advanced solid tumors, provided it is approved by the Therapeutic Goods Administration, TGA, for diagnostic use. Option C. Prioritize the use of the NGS panel for patients where existing evidence and established clinical guidelines demonstrate a clear impact on treatment selection or prognosis, while continuing to monitor emerging data for broader application. Option D. Adopt the NGS panel for all patients with advanced solid tumors based on its comprehensive profiling capabilities, assuming that more data will emerge to justify its use over time. The correct answer is B. Implement the NGS panel for all patients with advanced solid tumors, provided it is approved by the Therapeutic Goods Administration, TGA, for diagnostic use. Explanation: scenario analysis. This scenario presents a professional challenge in the application of novel biomarker testing in a clinical oncology setting. The challenge lies in balancing the potential benefits of personalized medicine, driven by biomarker identification, with the need for robust evidence of clinical utility and adherence to established guidelines. Clinicians must navigate the evolving landscape of diagnostic technologies while ensuring patient care remains evidence-based, cost-effective, and ethically sound, particularly when new tests lack widespread validation or clear reimbursement pathways. Correct approach analysis. The correct approach represents best professional practice by prioritizing the use of biomarkers that have demonstrated clinical utility and are supported by evidence-based guidelines. This aligns with the principles of evidence-based medicine, which are fundamental to the Royal Australasian College of Physicians, RAC, standards for clinical practice. Specifically, it adheres to the ethical imperative of providing care that is both safe and effective, avoiding the premature adoption of unproven technologies that could lead to unnecessary costs, patient anxiety, or suboptimal treatment decisions. Regulatory frameworks in Australia, such as those governing medical devices and diagnostic services, implicitly support the use of validated and approved diagnostic tools. Furthermore, professional conduct codes emphasize the importance of staying current with medical knowledge and applying it judiciously. Incorrect approaches analysis. One incorrect approach involves routinely ordering a broad panel of investigational biomarkers for all patients with a specific cancer type, irrespective of established clinical guidelines or evidence of their impact on treatment decisions. This fails to adhere to the principle of judicious resource allocation and may expose patients to the psychological and financial burden of tests with uncertain clinical relevance. It also risks generating data that is not actionable, potentially leading to diagnostic uncertainty or inappropriate therapeutic interventions, which contravenes the RAC commitment to high-quality patient care. Another incorrect approach is to disregard biomarker testing entirely, even when evidence suggests it could significantly influence treatment selection for a particular patient. This represents a failure to embrace advancements in oncology that are supported by robust data and could lead to improved patient outcomes. It may also be considered a failure to provide the best available care, particularly if established guidelines recommend such testing for specific patient populations or tumor subtypes. A third incorrect approach is to rely solely on the marketing claims of diagnostic companies for novel biomarkers, without independent critical appraisal of the supporting scientific literature and clinical validation data. This bypasses the essential process of evidence-based decision-making and could lead to the adoption of tests that are not rigorously validated, potentially compromising patient safety and the integrity of clinical practice. Professional reasoning. Professionals should adopt a decision-making process that involves critically evaluating the evidence supporting the use of any biomarker test. This includes consulting peer-reviewed literature, established clinical guidelines, e.g., those from professional bodies and government health agencies, and considering the specific clinical context of the individual patient. A systematic approach involves assessing the test's analytical validity, and clinical utility. Professionals should also be aware of local and national guidelines regarding diagnostic testing, reimbursement, and the ethical implications of using novel technologies. Collaboration with multidisciplinary teams and seeking expert opinion can further inform these decisions. Question 10. The audit findings indicate a concerning rate of grade 3 or higher mucositis in patients receiving a specific platinum-based chemotherapy regimen for advanced lung cancer. A review of recent cases reveals that, while mucositis is being managed symptomatically, there is a lack of proactive strategies being consistently implemented across the unit. What is the most appropriate immediate next step for the clinical oncology team? Option A. Immediately discontinue the platinum-based chemotherapy regimen for all patients until the cause of the increased mucositis rate can be definitively identified. Option B. Implement a unit-wide protocol for routine prophylactic oral care and early intervention for mucositis, including patient education on oral hygiene and symptom reporting, and review the chemotherapy regimen's dosing schedule and infusion times in light of the audit findings. Option C. Advise individual patients to seek advice from their general practitioners regarding over-the-counter oral care products to manage their mucositis. Option D. Continue current symptomatic management of mucositis, focusing on individual patient responses, and await further data before considering any changes to unit protocols. The correct answer is B. Implement a unit-wide protocol for routine prophylactic oral care and early intervention for mucositis, including patient education on oral hygiene and symptom reporting, and review the chemotherapy regimen's dosing schedule and infusion times in light of the audit findings. Explanation. Scenario analysis. This scenario is professionally challenging due to the potential for significant patient harm from a common but serious adverse effect, coupled with the need for rapid, evidence-based intervention. The audit findings highlight a systemic issue in the management of a specific chemotherapy regimen, requiring not just individual patient care adjustments, but also a review of institutional protocols and clinician education. The pressure to act swiftly while adhering to best practice guidelines and regulatory expectations for patient safety and quality improvement is paramount. Correct approach analysis. The correct approach involves a multifaceted strategy that prioritizes immediate patient safety, thorough investigation, and systemic improvement. This aligns with the Royal Australasian College of Physicians, RACP, standards for clinical practice, which emphasize evidence-based medicine, patient-centered care, and continuous quality improvement. Specifically, it reflects the ethical obligation to minimize harm, non-maleficence, and act in the patient's best interest, beneficence. The prompt investigation and management of the adverse event, followed by a review of institutional protocols and education, directly addresses the audit findings and aims to prevent recurrence, fulfilling the principles of professional accountability and quality assurance mandated by the RACP. Incorrect approach is analysis, an approach that focuses solely on individual patient management without addressing the systemic issue identified by the audit, fails to meet professional standards for quality improvement and patient safety. This could lead to repeated adverse events in other patients receiving the same regimen, violating the principle of beneficence on a broader scale, and potentially contravening guidelines on institutional responsibility for patient care. An approach that delays investigation or management of the adverse effect, or relies on anecdotal evidence rather than established guidelines, demonstrates a failure in adhering to evidence-based practice. This risks patient harm and falls short of the professional duty of care expected by the RACP and regulatory bodies overseeing healthcare quality in Australia. Such delays could be construed as professional negligence. An approach that dismisses the audit findings without a thorough review or implements superficial changes without addressing the root cause is professionally unacceptable. It indicates a lack of commitment to quality improvement and patient safety, potentially leading to continued adverse events and a failure to meet the standards of professional conduct expected of RACP fellows. This could also have implications under Australian healthcare accreditation standards. Professional reasoning. Professionals should adopt a systematic approach to adverse events. This involves immediate patient assessment and management, followed by a thorough investigation into the cause, which may include reviewing patient factors, drug administration, and institutional protocols. The findings of this investigation should then inform a review of existing protocols and the implementation of targeted education for relevant staff. This iterative process of identification, investigation, and improvement is central to maintaining high standards of patient care and fulfilling professional obligations. Question 11. Operational review demonstrates a significant discrepancy between the initial histopathology report for a complex oncology case and the findings of a subsequent peer review conducted by a senior colleague. The reporting pathologist maintains their original interpretation, while the peer reviewer believes a critical diagnostic element has been overlooked, potentially altering the treatment pathway. What is the most appropriate course of action for the clinical oncology department to ensure patient safety and uphold professional standards? Option A. Dismiss the peer review findings as a difference in interpretation and proceed with the treatment plan based on the original report, assuming the reporting pathologist's expertise. Option B. Immediately amend the original report based on the peer reviewer's findings and inform the treating clinician, without further discussion with the reporting pathologist, to expedite patient management. Option C. Inform the Medical Board of Australia of a potential diagnostic error by the reporting pathologist, pending a full investigation into the discrepancy. Option D. Facilitate a joint review of the slides by the reporting pathologist and the peer reviewer, with the involvement of a third independent senior pathologist if consensus cannot be reached, to determine the definitive diagnosis and ensure appropriate communication with the treating team. The correct answer is D. Facilitate a joint review of the slides by the reporting pathologist and the peer reviewer, with the involvement of a third independent senior pathologist if consensus cannot be reached, to determine the definitive diagnosis and ensure appropriate communication with the treating team. Explanation. Scenario analysis. This scenario presents a professional challenge due to a discrepancy between a pathologist's initial report and subsequent findings during a peer review. The core of the challenge lies in balancing the need for accurate patient care, the integrity of the diagnostic process, and the professional accountability of the reporting pathologist. The potential for patient harm, the impact on the treating clinician's management decision, and the implications for the pathologist's professional standing necessitate a careful and ethically sound approach. Correct approach analysis. The correct approach involves a structured, transparent, and collaborative process to address the discrepancy. This aligns with the principles of good medical practice and the ethical obligations of medical professionals in Australia. Specifically, it upholds the duty of care to the patient by ensuring the most accurate diagnosis informs treatment. It also adheres to professional standards by facilitating a constructive review process that aims to identify and rectify errors, thereby improving diagnostic quality and patient safety. This approach respects the professional integrity of all involved while prioritizing patient well-being. The Royal Australasian College of Physicians, RACP, Guidelines and the Medical Board of Australia's Good Medical Practice. A code of conduct for doctors in Australia would support such a transparent and collaborative resolution. Incorrect approaches analysis. One incorrect approach would be to dismiss the peer review findings without thorough investigation. This fails to uphold the duty of care to the patient, as it risks perpetuating an inaccurate diagnosis and potentially leading to inappropriate treatment. Ethically, it demonstrates a lack of professional responsibility and a disregard for quality assurance processes. It also undermines the peer review system, which is crucial for maintaining high standards in pathology. Another incorrect approach would be to immediately report the reporting pathologist for misconduct without first attempting to understand the discrepancy and seeking clarification. This could be premature and damaging to the pathologist's reputation and career, especially if the discrepancy is a minor interpretation difference or a clerical error that can be easily rectified. It bypasses the opportunity for learning and professional development that a constructive review process offers. A third incorrect approach would be to alter the original report without informing the reporting pathologist or the treating clinician of the discrepancy and the subsequent review. This constitutes a lack of transparency and honesty, potentially misleading the treating team and the patient about the diagnostic process. It also violates principles of professional integrity and accountability. Professional reasoning. Professionals facing such a situation should adopt a systematic decision-making process. This involves 1. Acknowledging the discrepancy and the importance of the peer review findings. 2. Initiating a confidential and respectful discussion with the reporting pathologist to understand their perspective and the basis of their original report. 3. Collaboratively reviewing the slides and relevant clinical information to determine the nature and significance of the discrepancy. 4. If a significant error is identified, following established protocols for amending reports, ensuring appropriate communication with the treating clinician and patient, and documenting the process. 5. Using the experience as a learning opportunity for both the reporting pathologist and the peer reviewer, potentially involving further education or quality improvement initiatives. This process prioritizes patient safety, professional integrity, and continuous improvement in diagnostic accuracy, all of which are paramount in Australian medical practice. Question 12. Compliance review shows that a clinical oncology practice is considering the broader implementation of liquid biopsy testing. Which of the following approaches best aligns with current Australian regulatory frameworks and evidence-based clinical practice guidelines for the use of liquid biopsies in oncology? Option A. solely relying on liquid biopsy results for treatment decisions across all cancer types and stages, irrespective of the test's validation status or supporting clinical evidence. Option B, offering liquid biopsies for treatment response monitoring and MRD detection in all cancer types without established protocols for interpretation and actionability within the Australian healthcare system. Option C, routinely offering liquid biopsies for early cancer screening in asymptomatic individuals without specific high-risk factors. Option D, prioritizing the use of liquid biopsies for established indications where clinical utility and analytical validity are well documented and supported by Australian guidelines, such as identifying actionable mutations in advanced NSCLC when tissue biopsy is insufficient. The correct answer is C, routinely offering liquid biopsies for early cancer screening in asymptomatic individuals without specific high-risk factors. Explanation: scenario analysis. This scenario presents a professional challenge due to the evolving landscape of liquid biopsy integration into routine clinical oncology practice within Australia. Clinicians must navigate the balance between adopting promising new technologies and adhering to established evidence-based guidelines and regulatory frameworks. The rapid pace of research in liquid biopsies, particularly concerning their utility in early detection, minimal residual disease, MRD monitoring, and treatment selection, necessitates a critical evaluation of their current validated applications versus their potential future roles. Ensuring patient safety, equitable access, and responsible resource allocation are paramount. Correct approach analysis. The correct approach represents best professional practice by prioritizing the use of liquid biopsies in settings where their clinical utility and analytical validity have been robustly established and are supported by current Australian guidelines and evidence. This aligns with the principles of evidence-based medicine, which are fundamental to the Royal Australasian College of Physicians (RAC) standards for clinical practice. Specifically, utilizing liquid biopsies for established indications, such as identifying actionable mutations in advanced non-small cell lung cancer (NSCLC), when tissue biopsy is insufficient or contraindicated, is a validated and guideline-supported application. This approach ensures that patient care is based on reliable diagnostic information, minimizing the risk of inappropriate treatment decisions and maximizing the potential benefit from targeted therapies. It also reflects a responsible adoption of technology, awaiting further validation for less established applications. Incorrect approaches analysis. One incorrect approach involves routinely recommending liquid biopsies for early-stage cancer screening in asymptomatic individuals without specific high-risk factors or established screening programs. This is professionally unacceptable because the analytical and clinical validity for widespread screening applications are not yet sufficiently established in the Australian context. Such use could lead to a high rate of false positives, unnecessary anxiety, further invasive investigations, and potential overdiagnosis, which are not supported by current regulatory approvals or clinical guidelines. This approach fails to adhere to the principle of first, do no harm, and represents an unvalidated application of the technology. Another incorrect approach is to solely rely on liquid biopsy results for treatment decisions in all cancer types and stages, irrespective of the specific test's validation status or the availability of supporting clinical evidence. This is professionally unacceptable, as it bypasses the established diagnostic pathways and the need for comprehensive molecular profiling, where indicated by tissue biopsy. Different liquid biopsy platforms and assays have varying sensitivities and specificities, and their utility is context-dependent. Using them as a sole determinant without considering the broader clinical picture and the limitations of the specific test can lead to suboptimal or erroneous treatment choices, contravening the RAC emphasis on rigorous diagnostic evaluation and evidence-based management. A further incorrect approach is to offer liquid biopsies for monitoring treatment response or detecting MRD in all cancer types without clear evidence of clinical benefit or established protocols for interpretation and actionability within the Australian healthcare system. While promising, the widespread application of liquid biopsies for these purposes is still under active investigation and may not be validated for all tumor types or treatment regimens. Uncritical adoption can lead to misinterpretation of results, unnecessary patient anxiety, and potentially costly interventions based on uncertain clinical significance, failing to meet the standards of responsible and evidence-based medical practice. Professional reasoning. Professionals should adopt a systematic approach to integrating new diagnostic technologies like liquid biopsies. This involves 1. Staying abreast of the latest peer-reviewed literature and evidence regarding analytical and clinical validity. 2. Consulting current Australian guidelines from relevant professional bodies, e.g., Cancer Australia, RAC, specific oncology societies. 3. Understanding the specific indications for which a particular liquid biopsy test has been validated and approved by regulatory bodies, e.g., Therapeutic Goods Administration (TGA). 4. Considering the patient's clinical context, including tumor type, stage, previous treatments, and the availability of alternative diagnostic methods. 5. Engaging in shared decision-making with patients, clearly explaining the benefits, limitations, and uncertainties associated with liquid biopsy use. 6. Advocating for and participating in research that further validates the utility of liquid biopsies in various clinical settings. Question 13. Cost-benefit analysis shows that next-generation sequencing, NGS, panels can identify actionable molecular alterations in a significant proportion of patients with advanced solid tumors. In the context of Australian clinical oncology practice and RAC guidelines, which of the following approaches best reflects responsible and compliant integration of NGS into patient care? Option A. Deferring NGS testing until it is universally recommended by all major international oncology societies and fully reimbursed by the Australian public healthcare system to avoid potential out-of-pocket expenses for patients. Option B. Prioritizing NGS testing only for patients with rare or previously untreatable cancers, and only after all conventional treatment options have been exhausted to conserve healthcare resources. Option C. Ordering an extensive NGS panel for any patient with advanced cancer, regardless of specific tumor type or prior treatment history, to maximize the chance of identifying a rare actionable mutation. Option D. Recommending NGS for patients with advanced solid tumors, where there is a strong clinical suspicion of an actionable mutation, supported by emerging evidence or established guidelines, and where the results are likely to directly inform treatment decisions or access to clinical trials. The correct answer is C. Ordering an extensive NGS panel for any patient with advanced cancer, regardless of specific tumor type or prior treatment history, to maximize the chance of identifying a rare actionable mutation. Explanation. Scenario analysis. This scenario presents a common challenge in modern oncology: the integration of advanced genomic technologies like next-generation sequencing, NGS, into routine clinical practice. Professional challenge lies in balancing the potential benefits of personalized medicine, as suggested by NGS, with the practical realities of resource allocation, evidence-based guidelines, and regulatory compliance within the Australian healthcare system. Clinicians must navigate the evolving landscape of genomic medicine, ensuring that diagnostic and therapeutic decisions are not only scientifically sound, but also ethically and legally defensible, adhering to the standards set by bodies like the Royal Australasian College of Physicians, RAC. Correct approach analysis. The correct approach prioritizes patient benefit and evidence-based practice within the Australian regulatory framework. This involves considering NGS for a patient when there is a clear clinical indication, supported by existing evidence or established clinical guidelines, and when the results are likely to directly inform treatment decisions or prognosis. This aligns with the principles of responsible medical practice and the ethical obligation to provide care that is both effective and appropriate. In Australia, the Therapeutic Goods Administration, TGA, regulates medical devices and in vitro diagnostics, and while NGS panels may not always be explicitly listed, their clinical utility and validation are paramount. Furthermore, adherence to professional standards and guidelines from the RAC ensures that the use of such technologies is aligned with the highest standards of clinical oncology practice. The decision to pursue NGS should be integrated into the patient's overall management plan, considering factors such as the availability of targeted therapies, the potential for clinical trial enrollment, and the patient's informed consent. Incorrect approach is analysis. One incorrect approach would be to order NGS solely based on a patient's desire for advanced testing, without a clear clinical rationale or established guidelines supporting its use in their specific situation. This could lead to unnecessary expenditure, potential for incidental findings that cause patient distress, and a failure to adhere to the principles of evidence-based medicine, which are implicitly expected within the RAC framework. Another incorrect approach would be to disregard NGS entirely, even when there is emerging evidence or a strong clinical suspicion that it could significantly alter management, simply due to a lack of widespread adoption or perceived cost. This would represent a failure to embrace potentially beneficial advancements and could lead to suboptimal patient care, contravening the RAC commitment to advancing clinical oncology. A third incorrect approach would be to order NGS without a thorough understanding of the test's limitations, the interpretability of its results, or the availability of subsequent targeted therapies or clinical trials. This could result in ordering a test that yields clinically unactionable information, leading to patient anxiety and misdirected clinical effort, and failing to meet the standards of responsible diagnostic practice. Professional reasoning. Professionals should adopt a systematic approach when considering NGS. This involves 1. Assessing the clinical question. Is there a specific therapeutic question that NGS might answer? 2. Reviewing the evidence. Is there established evidence supporting the use of NGS in this patient's cancer type and stage? Are there relevant Australian clinical guidelines or consensus statements? 3. Evaluating test utility. Will the NGS results likely lead to a change in management, access to targeted therapy, or enrollment in a clinical trial? 4. Considering patient factors. Has the patient been fully informed about the potential benefits, risks, limitations, and costs of NGS, and have they provided informed consent? 5. Consulting resources. Engaging with molecular tumor boards, genetic counselors, or other specialists where available to interpret complex genomic data and its clinical implications. 6. Adhering to regulatory frameworks. Ensuring that any diagnostic tests used are appropriately validated and that their use aligns with TGA regulations and professional standards. Question 14. Assessment of the optimal management strategy for a 65-year-old male presenting with a newly diagnosed, locally advanced rectal adenocarcinoma, confirmed by biopsy and staging CT scan showing involvement of adjacent perirectal fat, but no distant metastases. Preoperative MRI indicates potential for complete mesorrectal excision with clear margins if the tumor can be downstaged. The patient has mild comorbidities. What is the most appropriate initial management approach? Option A. Multidisciplinary team discussion to formulate a treatment plan, considering neoadjuvant chemoradiotherapy followed by surgical resection, or upfront surgery based on the MDT's assessment of resectability and potential benefits. Option B. Defer definitive treatment for 6 weeks to allow for further tumor regression and reassessment. Option C. Initiate neoadjuvant chemotherapy alone without radiotherapy, followed by reassessment for surgery. Option D. Proceed directly to upfront surgical resection with the aim of achieving clear margins, given the absence of distant metastases. The correct answer is A. Multidisciplinary team discussion to formulate a treatment plan, considering neoadjuvant chemoradiotherapy followed by surgical resection, or upfront surgery based on the MDT's assessment of resectability and potential benefits. Explanation. Scenario analysis. This scenario presents a common challenge in surgical oncology, balancing the immediate need for definitive surgical treatment with the potential for neoadjuvant therapy to improve surgical outcomes and patient prognosis. The challenge lies in determining the optimal sequence of treatment, considering the specific tumor characteristics, patient factors, and the evidence base for different approaches. The urgency of the diagnosis and the potential for disease progression add further complexity, requiring a prompt yet well-considered decision. Correct approach analysis. The correct approach involves a multidisciplinary team MDT discussion to formulate a comprehensive treatment plan. This aligns with best practice guidelines in oncology, which emphasize a holistic and evidence-based approach to cancer management. The MDT, comprising surgeons, medical oncologists, radiation oncologists, radiologists, pathologists, and other relevant specialists, can collectively assess the tumor stage, histology, patient comorbidities, and potential benefits of neoadjuvant therapy versus upfront surgery. This collaborative decision-making process ensures that all relevant factors are considered, leading to a plan that optimizes oncological outcomes, functional preservation, and patient quality of life. This approach is supported by the principles of evidence-based medicine and the ethical imperative to provide patient-centered care, as advocated by professional bodies such as the Royal Australasian College of Physicians. Incorrect approach is analysis, proceeding directly to surgery without considering neoadjuvant therapy, despite evidence suggesting its benefit for this tumor type and stage, represents a failure to adhere to best practice guidelines and potentially suboptimal patient care. This could lead to more extensive surgery than necessary, increased morbidity, and a less favorable oncological outcome. May also disregard established evidence that neoadjuvant treatment can downstage tumors, improve resectability, and potentially enhance survival. Delaying surgery indefinitely to pursue neoadjuvant therapy without a clear rationale or evidence of significant benefit for this specific case would also be professionally unacceptable. This could lead to disease progression, rendering surgery more challenging or even impossible, and negatively impacting prognosis. It fails to acknowledge the primary role of surgery in achieving local control and potentially curative intent for many solid tumors. Opting for a less aggressive surgical approach than indicated by the tumor stage and characteristics, solely to minimize immediate surgical morbidity, without adequate consideration of oncological principles and long-term outcomes, would be a significant ethical and professional failing. This prioritizes short-term surgical ease over optimal cancer management and patient survival. Professional reasoning. Professionals should employ a structured decision-making process that begins with a thorough review of all diagnostic information. This includes imaging, pathology, and staging. The next crucial step is to consult relevant evidence-based guidelines and literature pertaining to the specific cancer type and stage. Engaging in a multidisciplinary team discussion is paramount to integrate diverse expertise and perspectives. Patient preferences and values must also be actively sought and incorporated into the decision-making process. Finally, the chosen treatment plan should be clearly documented, with rationale explained to the patient, and subject to ongoing review and adjustment as needed. Question 15. Comparative studies suggest that, while certain cancers have higher incidence rates within specific demographic groups in Australia, the optimal approach to cancer prevention and screening for an individual patient involves a nuanced consideration of multiple factors. Given a 55-year-old male patient with a family history of colorectal cancer but no personal symptoms, which of the following represents the most appropriate initial discussion regarding cancer screening? Option A. Discussing the evidence for and against bowel cancer screening, including the benefits of early detection through fecal occult blood testing and colonoscopy, alongside the potential for false positives and harms associated with invasive procedures, and exploring the patient's personal preferences and risk tolerance. Option B. Advising against any screening at this time, as the patient is asymptomatic, and the potential harms of screening outweigh the benefits for individuals without symptoms. Option C. Focusing solely on prostate cancer screening, as it is a common cancer in men of this age group, and deferring any discussion of bowel cancer screening until the patient develops symptoms. Option D. Recommending immediate commencement of a comprehensive genetic screening panel for all common hereditary cancer syndromes, given the family history of colorectal cancer. The correct answer is A. Discussing the evidence for and against bowel cancer screening, including the benefits of early detection through fecal occult blood testing and colonoscopy, alongside the potential for false positives and harms associated with invasive procedures, and exploring the patient's personal preferences and risk tolerance. Explanation. This scenario presents a professional challenge due to the need to balance evidence-based guidelines with individual patient factors and the complexities of implementing population-level screening programs within the Australian healthcare context. The physician must navigate the nuances of screening recommendations, which are often based on population averages and may not perfectly align with every individual's risk profile or preferences. Furthermore, the ethical imperative to provide accurate, unbiased information and respect patient autonomy is paramount, especially when discussing screening that carries potential harms as well as benefits. The correct approach represents best professional practice by adhering to the principles outlined in the Royal Australasian College of Physicians (RACP) guidelines and relevant Australian public health legislation concerning cancer screening. It prioritizes shared decision-making, ensuring the patient is fully informed about the benefits, harms, and limitations of screening, allowing them to make a choice aligned with their values. This approach respects patient autonomy and upholds the ethical duty of care by providing evidence-based, personalized advice, an incorrect approach that focuses solely on the highest incidence cancer for the patient's demographic, without considering individual risk factors or patient preferences, fails to meet the standard of personalized care expected in clinical oncology. This could lead to unnecessary anxiety, false positives, or missed opportunities for early detection of other cancers if the patient has specific risk factors. Ethically, it disregards patient autonomy and the principle of beneficence by not tailoring recommendations to the individual. Another incorrect approach that emphasizes only the most aggressive screening modalities, irrespective of the patient's risk profile or the evidence supporting such intensity, would be professionally unacceptable. This could lead to overinvestigation, patient harm from invasive procedures, and significant psychological distress, violating the principle of non-maleficence. It also fails to adhere to the principle of justice by potentially diverting resources from individuals who might benefit more from less intensive screening. A further incorrect approach that dismisses screening entirely due to potential harms, without a thorough assessment of the patient's individual risk and the proven benefits of screening for specific cancers in the Australian context, would be a failure to uphold the duty of care. While acknowledging harms is important, a blanket refusal to discuss or recommend evidence-based screening options for appropriate individuals is not aligned with public health recommendations or the RAC commitment to cancer prevention. The professional decision-making process for similar situations should involve a systematic approach. First, thoroughly assessing the patient's individual risk factors for various cancers, considering family history, lifestyle, and genetic predispositions. Second, consulting current evidence-based screening guidelines relevant to the Australian population, as published by bodies like Cancer Australia and endorsed by the RAC. Third, engaging in a comprehensive discussion with the patient, explaining the rationale for screening, the specific benefits and harms of each recommended test, and the implications of screening results. Finally, facilitating a shared decision-making process where the patient's values, preferences, and understanding are central to the final decision regarding screening participation. Question 16. Process analysis reveals that a patient with advanced metastatic lung cancer, who has a poor performance status and significant comorbidities, is being considered for palliative chemotherapy. The evidence for significant survival benefit in this specific subgroup is limited, and the potential for severe treatment-related toxicity is high, which could further compromise their quality of life. The patient expresses a desire to try everything to extend their life. Which of the following approaches best reflects the RAC guidelines for managing such a complex clinical scenario? Option A. Engage in a detailed discussion with the patient and their family about the limited evidence for significant benefit in their specific situation, the high risk of severe toxicity that could negatively impact their quality of life, and explore their personal goals of care and values to collaboratively determine the most appropriate management plan. Option B. Administer the chemotherapy regimen as planned, but withhold detailed information about the potential for severe side effects to avoid causing undue distress to the patient, who is already anxious about their prognosis. Option C. Recommend against chemotherapy, explaining that given their poor performance status and comorbidities, the risks far outweigh any potential benefits, and focus solely on best supportive care. Option D. Proceed with the proposed chemotherapy regimen immediately, as the patient has expressed a strong desire to try everything to extend their life, and it is the clinician's duty to offer all available treatments. The correct answer is D. Proceed with the proposed chemotherapy regimen immediately, as the patient has expressed a strong desire to try everything to extend their life, and it is the clinician's duty to offer all available treatments. Explanation. This scenario presents a common yet complex challenge in clinical oncology, managing patient expectations and ensuring informed consent when treatment efficacy is uncertain and side effects are significant. The professional challenge lies in balancing the potential benefits of chemotherapy against its known toxicities, while respecting patient autonomy and adhering to the principles of good medical practice as outlined by the Royal Australasian College of Physicians, RAC. The RAC guidelines emphasize shared decision-making, clear communication of risks and benefits, and the importance of patient values in treatment choices. The correct approach involves a thorough discussion of the evidence supporting the proposed chemotherapy regimen for the patient's specific stage and type of cancer, including realistic estimates of response rates and survival benefits. Crucially, This discussion must also encompass the potential side effects, their management, and their impact on the patient's quality of life. The patient's goals of care, values, and preferences must be actively elicited and integrated into the decision-making process. This aligns with the RAC commitment to patient-centered care and the ethical imperative of informed consent, ensuring the patient can make a voluntary and informed choice about their treatment. An incorrect approach would be to present chemotherapy as a guaranteed cure or to downplay the severity of potential side effects. This constitutes a failure of transparency and can lead to a breach of informed consent, as the patient would not have a true understanding of the risks and benefits. Another incorrect approach would be to proceed with chemotherapy without adequately exploring the patient's understanding of their condition and treatment options, or without considering their personal circumstances and preferences. This disregards the principle of shared decision-making and can result in a treatment plan that is not aligned with the patient's values or best interests, potentially leading to significant distress and dissatisfaction. Professionals should approach such situations by first establishing a clear understanding of the patient's diagnosis, prognosis, and treatment options based on current evidence and guidelines. They should then engage in an open and honest dialogue, using clear and understandable language to explain the rationale for the proposed treatment, its expected outcomes, both positive and negative, and alternative approaches. Actively listening to the patient's concerns, fears, and goals is paramount. The decision-making process should be a collaborative one, empowering the patient to make a choice that is best for them, supported by the clinician's expertise and guidance. Question 17. To address the challenge of a patient with newly diagnosed early-stage lung cancer who expresses a strong preference for a less aggressive, non-surgical treatment modality, despite clear evidence supporting the efficacy of radical radiotherapy as a primary treatment option, and who cites anecdotal information from online forums as the basis for their decision. What is the most ethically and professionally appropriate course of action for the clinical oncologist? Option A. Insist on radical radiotherapy as the only acceptable treatment, explaining that their online information is unreliable and that the oncologist's professional judgment must prevail. Option B. Engage in a detailed discussion with the patient to understand the specific concerns driving their preference. Provide comprehensive, evidence-based information about the benefits, risks, and alternatives of radical radiotherapy, and collaboratively explore their values and priorities to reach a shared decision regarding treatment. Option C. Inform the patient that their decision is not aligned with best practice and suggest they seek care elsewhere if they are unwilling to accept the recommended radiotherapy. Option D. Proceed with the patient's preferred less aggressive treatment without further discussion, as their autonomy to choose their treatment is paramount. The correct answer is B. Engage in a detailed discussion with the patient to understand the specific concerns driving their preference. Provide comprehensive, evidence-based information about the benefits, risks, and alternatives of radical radiotherapy, and collaboratively explore their values and priorities to reach a shared decision regarding treatment. Explanation. This scenario presents a professional challenge due to the inherent conflict between a patient's expressed wishes and the clinician's understanding of the optimal treatment pathway, particularly when the patient's understanding of the treatment's nature and potential outcomes may be influenced by misinformation. The clinician must navigate this ethical tightrope, balancing patient autonomy with the duty of beneficence and non-maleficence, all within the framework of Australian medical practice and the Royal Australasian College of Physicians, RAC, guidelines. The correct approach represents best professional practice by prioritizing comprehensive patient education and shared decision-making. This aligns with the Australian Medical Association AMA Code of Ethics, which emphasizes the importance of informed consent and respecting a patient's right to make decisions about their own healthcare, even if those decisions differ from the clinician's recommendation. Specifically, it upholds the principle of autonomy by ensuring the patient has sufficient, accurate information to make a truly informed choice. It also addresses the duty of beneficence by attempting to correct potential misunderstandings that could lead to suboptimal or harmful treatment decisions. The RAC emphasis on patient-centered care and ethical conduct further supports this approach. An incorrect approach that involves overriding the patient's wishes without adequate exploration of their reasoning or providing sufficient corrective information fails to uphold the principle of autonomy. This could be seen as paternalistic and may violate the patient's right to self-determination, a cornerstone of ethical medical practice in Australia. Furthermore, it risks alienating the patient and damaging the therapeutic relationship, potentially leading to non-adherence or a complete breakdown in care. Another incorrect approach that involves proceeding with a treatment the patient explicitly refuses, even if the clinician believes it is in their best interest, constitutes a clear breach of informed consent and battery. This directly contravenes the legal and ethical requirements for medical treatment in Australia, which mandate that all interventions must be consented to by the patient. A third incorrect approach that involves simply withdrawing from the case without attempting to resolve the misunderstanding or find an alternative solution fails to meet the professional obligation to care for the patient. While a clinician may have the right to refuse to provide a specific treatment, abandoning a patient without ensuring continuity of care or exploring all avenues for resolution is ethically problematic and may fall short of professional standards expected by the RAC. The professional decision-making process in such situations should involve a structured approach. First, actively listen to and understand the patient's concerns and the source of their misinformation. Second, provide clear, unbiased, and comprehensive education about the proposed treatment, including its benefits, risks, alternatives, and the rationale behind the recommendation, using language the patient can understand. Third, explore the patient's values and priorities to understand how they weigh different outcomes. Fourth, engage in shared decision-making, where the clinician and patient collaboratively determine the best course of action, respecting the patient's final decision within the bounds of safe and ethical practice. If a significant impasse remains, seeking a second opinion or involving a multidisciplinary team can be beneficial. Question 18. Strategic planning requires an oncologist to consider the optimal approach to palliative surgery for a patient with advanced, unresectable metastatic colorectal cancer experiencing significant bowel obstruction and pain. The patient is frail but has expressed a desire to improve their quality of life and reduce their symptom burden. What is the most appropriate initial step in the strategic planning process? Option A. Advise the patient that palliative surgery is unlikely to offer significant benefit given the advanced stage of their disease and focus solely on medical management of symptoms. Option B. Refer the patient for a detailed psychological assessment to determine their readiness for surgical intervention, deferring the discussion of surgical options until this assessment is complete. Option C. Proceed directly with surgical consultation for palliative bypass surgery, assuming the patient's desire for symptom relief necessitates immediate operative intervention. Option D. Initiate a multidisciplinary team discussion involving surgical oncology, palliative care, and medical oncology to comprehensively assess the patient's overall condition, discuss potential surgical interventions for symptom relief, and align on a shared care plan that prioritizes the patient's goals of care. The correct answer is D. Initiate a multidisciplinary team discussion involving surgical oncology, palliative care, and medical oncology to comprehensively assess the patient's overall condition, discuss potential surgical interventions for symptom relief, and align on a shared care plan that prioritizes the patient's goals of care. Explanation. This scenario presents a professionally challenging situation due to the inherent complexity of balancing aggressive cancer treatment with the patient's quality of life and symptom burden. The oncologist must navigate the ethical imperative to offer potentially life-prolonging interventions while simultaneously acknowledging the limitations of curative intent and the potential for palliative surgery to cause significant morbidity. Careful judgment is required to assess the patient's overall condition, prognosis, and personal values, ensuring that any surgical intervention aligns with their goals of care. The correct approach represents best professional practice because it prioritizes a comprehensive, multidisciplinary assessment and shared decision-making process, aligning with the principles of patient-centered care and the ethical guidelines governing medical practice in Australia. Specifically, it adheres to the Royal Australasian College of Physicians, RAC, standards for clinical oncology, which emphasize evidence-based practice, patient autonomy, and the judicious use of resources. Engaging a palliative care specialist early ensures that symptom management and psychosocial support are integrated into the treatment plan, maximizing the patient's comfort and dignity. Discussing realistic outcomes and potential complications with the patient and their family in line with informed consent principles is paramount. An incorrect approach that focuses solely on the technical feasibility of palliative surgery, without a thorough assessment of the patient's overall condition and goals of care, represents a significant ethical failure. This could lead to a patient undergoing a burdensome procedure with little to no benefit, causing unnecessary suffering and potentially hastening decline, which contravenes the principle of non-maleficence. Another incorrect approach that dismisses palliative surgery outright without considering its potential to alleviate symptoms or improve quality of life, even in the context of advanced disease, may fail to uphold the patient's right to explore all reasonable treatment options and could be perceived as a lack of compassion. A third incorrect approach that prioritizes aggressive surgical intervention over symptom control, without adequately addressing the patient's pain and distress, would be a failure to meet the fundamental requirements of palliative care, and could be seen as a breach of professional duty to relieve suffering. Professionals should employ a decision-making framework that begins with a thorough understanding of the patient's diagnosis, stage of disease, and overall prognosis. This should be followed by a comprehensive assessment of their functional status, symptom burden, and psychosocial needs. Crucially, open and honest communication with the patient and their family about treatment options, including the potential benefits and harms of palliative surgery, is essential. Collaboration with a multidisciplinary team, including palliative care specialists, surgeons, and allied health professionals, ensures a holistic approach. The final decision should be guided by the patient's values and preferences, respecting their autonomy and right to self-determination. Question 19. Quality control measures reveal that a frequently used diagnostic ultrasound machine in the oncology department is producing images with subtle but persistent artifacts that were not present during its last scheduled maintenance 6 months ago. The machine is still functioning and producing images that the sonographer believes are interpretable. Which of the following actions best upholds the professional and regulatory standards for diagnostic imaging in Australia? Option A. Rely on the sonographer's subjective assessment that the images are still interpretable and continue with routine use until the next scheduled maintenance. Option B. Continue using the ultrasound machine, but instruct the sonographer to make a note of the artifacts on each report and schedule a routine service at the next available appointment. Option C. Immediately cease using the ultrasound machine and schedule an urgent recalibration and validation by a qualified biomedical engineer. Option D. Attempt to troubleshoot the artifacts by adjusting the machine settings and consulting online forums for potential solutions before engaging a biomedical engineer. The correct answer is C. Immediately cease using the ultrasound machine and schedule an urgent recalibration and validation by a qualified biomedical engineer. Explanation. This scenario presents a professional challenge due to the potential for suboptimal diagnostic accuracy and patient safety if ultrasound equipment is not maintained and validated according to established standards. The Royal Australasian College of Physicians, RACP, clinical oncology exam emphasizes adherence to best practices and regulatory compliance in all aspects of patient care, including the use of diagnostic imaging. The correct approach, which involves immediate cessation of use and scheduling of recalibration and validation by a qualified biomedical engineer, represents best professional practice. This aligns with the principles of quality assurance and patient safety, mandated by Australian healthcare regulations and RACP guidelines. Specifically, it upholds the duty of care to patients by ensuring that diagnostic information used for treatment planning is reliable and accurate. Failure to do so could lead to misdiagnosis, inappropriate treatment, and adverse patient outcomes, all of which would be considered professional and regulatory breaches. An incorrect approach of continuing to use the ultrasound machine while awaiting a routine service is professionally unacceptable. This constitutes a failure to adhere to quality control protocols and a disregard for the potential impact on diagnostic integrity. Ethically and regulatorily, this approach breaches the principle of beneficence, acting in the patient's best interest, and non-maleficence, avoiding harm. It also contravenes the implicit requirement for equipment to be fit for purpose. Another incorrect approach, that of relying solely on the operator's subjective assessment of image quality, is also professionally unacceptable. While operator experience is valuable, it cannot replace objective, quantifiable validation of equipment performance. This approach neglects the need for standardized quality assurance procedures and opens the door to subtle but significant degradations in image quality that may not be immediately apparent to the operator, but could impact diagnostic accuracy. This represents a failure to meet the expected standards of professional diligence and a potential breach of regulatory requirements for equipment validation. The professional decision-making process in such a situation should involve a systematic approach to quality assurance. Upon identification of a potential equipment malfunction or deviation from expected performance, the immediate priority is patient safety. This necessitates halting the use of the affected equipment until its integrity can be objectively verified. The next step involves engaging qualified personnel for repair and recalibration, followed by rigorous validation to ensure it meets all performance specifications before reintroducing it into clinical practice. This structured approach ensures that diagnostic services remain reliable and that patient care is not compromised by faulty equipment. Question 20. Risk assessment procedures indicate that a patient with advanced refractory solid malignancy may benefit from a novel therapeutic agent designed to modulate the tumor microenvironment by targeting specific immune checkpoints. Which of the following represents the most appropriate next step in evaluating this treatment option? Option A. Prescribing the novel agent based on anecdotal reports from colleagues regarding its effectiveness in similar patient populations. Option B. Immediately initiating treatment with the novel agent, given its promising preclinical efficacy data and the patient's refractory disease. Option C. Deferring consideration of the novel agent until it is widely adopted and included in established national treatment guidelines. Option D. Reviewing comprehensive preclinical data and early-phase clinical trial results for the agent, alongside consulting with relevant specialists and considering the patient's specific tumor biology and performance status. The correct answer is D. Reviewing comprehensive preclinical data and early-phase clinical trial results for the agent, alongside consulting with relevant specialists and considering the patient's specific tumor biology and performance status. Explanation. Scenario analysis. This scenario presents a professional challenge due to the complexity of the tumor microenvironment, TME, and its evolving understanding in clinical oncology. The challenge lies in translating emerging research on TME modulation into actionable, evidence-based treatment strategies that are both safe and effective for individual patients. Clinicians must navigate a landscape of novel therapeutic targets and agents, balancing potential benefits against risks, while adhering to established clinical guidelines and the principles of patient-centered care. The rapid pace of research necessitates continuous learning and critical appraisal of new data, making it difficult to definitively establish best practice for TME-targeted therapies in all contexts. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of novel TME-modulating therapies. This involves rigorous assessment of preclinical data, early-phase clinical trial results, and any available real-world evidence. Crucially, it necessitates consultation with multidisciplinary teams, including researchers, pharmacologists, and other oncologists, to gain diverse perspectives and ensure a comprehensive understanding of the agent's mechanism, potential toxicities, and predicted efficacy within specific tumor types and patient population. Adherence to the principles of good clinical practice, as outlined by regulatory bodies like the Therapeutic Goods Administration, TGA in Australia, and professional colleges such as the Royal Australasian College of Physicians, RACP, mandates that treatment decisions are informed by the highest quality evidence and are tailored to individual patient circumstances. This approach ensures patient safety, optimizes resource allocation, and aligns with the ethical imperative to provide the best possible care. Incorrect approach is analysis. An incorrect approach would be to prematurely adopt a novel TME-modulating therapy based solely on promising preclinical data or anecdotal reports without robust clinical validation. This represents a failure to adhere to the evidence-based medicine paradigm, which is a cornerstone of professional oncology practice in Australia. Such an approach could lead to patient harm due to unforeseen toxicities or lack of efficacy, and would contravene the RACP ethical guidelines regarding responsible innovation and patient safety. Another incorrect approach would be to dismiss novel TME-modulating therapies entirely due to a lack of widespread clinical adoption or established guidelines. While caution is warranted, an overly conservative stance can hinder progress and deny patients access to potentially life-saving treatments. This would be a failure to engage with the evolving scientific landscape and could be seen as a dereliction of the professional duty to explore and evaluate new therapeutic avenues that may benefit patients. A third incorrect approach would be to implement TME modulating therapies without a clear understanding of the specific TME characteristics of the patient's tumor or the mechanism of action of the proposed agent. This demonstrates a lack of critical appraisal and a failure to individualize treatment, which is contrary to best practice. It risks administering ineffective or even detrimental treatments, violating the principles of beneficence and non-maleficence. Professional reasoning. Professionals should approach novel TME modulating therapies with a framework that integrates scientific inquiry, clinical judgment, and ethical considerations. This involves 1. Staying abreast of the latest research through peer-reviewed literature, scientific conferences, and expert networks. 2. Critically appraising the quality and relevance of preclinical and clinical data. 3. Engaging in thorough multidisciplinary team discussions to explore all facets of a potential treatment. 4. Considering the patient's individual clinical status, preferences, and values. 5. Consulting relevant guidelines and regulatory requirements from bodies like the TGA and RAC. 6. Documenting the rationale for treatment decisions meticulously. This systematic process ensures that decisions are well-informed, ethically sound, and aligned with the highest standards of patient care within the Australian regulatory and professional landscape.